Thank you for attending tonight's Ask the Experts virtual event on sleep health. I'm Dr. Alan Kaminsky, head neck surgeon at the Cleveland Clinic. Joining me tonight are specialists from Cleveland Clinic's Sleep Disorder Center and Pulmonary Medicine. We're here tonight to answer your questions and provide details on sleep health topics, including what happens to your body when you sleep? How much sleep do you really need? What type of sleep test and treatment for snoring might be right for you? What are tips for improving your sleep hygiene? How do you diagnose, test, and treat other sleep disorders, including sleep apnea, insomnia, and shift work disorders? We had nearly 800 questions submitted by our audience, so we'll do our best to answer as many questions as we can. We'll also send out an email after the event that includes resources on sleep health. So with all that said, let's take a few minutes to do introductions, and then we'll dive right into the question and answer portion of our event. To kick things off, again, I'm Dr. Alan Kaminsky. I'm a head and neck surgeon and tonight's moderator. I've been practicing otolaryngology, or ear, nose, and throat, for just over 32 years. I've also become board certified in sleep medicine, and my practice focuses on both ENT problems and surgical management of obstructive sleep apnea and snoring. The most common thing I see are people who have difficulty with CPAP and need alternative methods for treating their obstructive sleep apnea. Next on the panel, I'd like to introduce Dr. Jennifer Brubaker.
Hi, my name is Jennifer Brubaker. I'm a nurse practitioner. I am an employee of the Sleep Center and the Pediatric Be Well Clinic. My areas of expertise and interest in sleep medicine include any pediatric and adult sleep disorder, with a primary focus on adults and children carrying excess weight.
Next, I'd like to introduce Dr. Don Decoy.
Hi, I'm Don Decoy. I'm a physician in the Pulmonary and Critical Care Medicine, the Respiratory Institute at the Cleveland Clinic, board certified in those specialties, and also a board certified sleep medicine physician. My interests are obstructive sleep apnea, central sleep apnea, and hypersomnia disorders such as narcolepsy and idiopathic hypersomnia. Thank you.
And finally, I'd like to introduce Dr. Pina Urbaya.
Hi, I'm Dr. Pina Urbaya. I'm a sleep medicine specialist here at Cleveland Clinic at main campus. I see primarily adult patients with different sleep disorders such as sleep apnea, insomnia, circadian rhythm disorders, restless legs, and other movement disorders during sleep. I am a sleep medicine board certified and internal medicine board certified. And even though I see different patients from different backgrounds, given that I speak both English and Spanish, I see quite a few Spanish-speaking patients as well.
Well, thanks for all your introductions. As you can see, we have quite an esteemed panel here. So now it's time to answer your questions. Again, we received almost 800, including topics ranging from snoring and insomnia to sleep apnea and shift work sleep disorder. So we'll attempt to answer as many as we can for the next 45 minutes, but we won't get to 800. First, we're going to start off with Dr. Pina Urbaya. Our most common question, here it is. I wake up every night at 2 or 3 o'clock in the morning and have a hard time getting back to sleep. What's going on, and how do I fix this?
Well, it sounds like this is one of my typical patients that I generally see. So it sounds like there might be some problem with insomnia. And what is insomnia? It's a medical condition where the brain is in a hyperarousal state. So how do we fix this? It depends on what is causing this, because in many occasions, there might be some concomitant sleep disorders, and one of these disorders can be obstructive sleep apnea. And sometimes when we treat the sleep apnea, those awakenings that happen in the middle of the night, they resolve. But if we are talking about insomnia itself, there are many reasons why this may be happening. And how can you fix this? A very important recommendation is that people should try to go to bed whenever they feel sleepy. So sometimes when I spoke with my colleagues from behavioral sleep medicine, they make this great comparison of, okay, when you want to grab something, you go to the fridge and grab something instead of standing in front of the refrigerator and waiting to feel hungry. So the same thing we do in patients who have difficulties staying asleep. Another important recommendation will be if you wake up and you cannot fall asleep again within 15, 20 minutes, it is highly recommended that you get off the room and try to do some activities that promote the sleep. And what could be those activities? Could be reading something that is not entertaining, listening to relaxing music, doing some meditation and mindfulness. It's very important to do those type of activities instead of watching TV, being on the phone. Sometimes patients, they decide to eat, to drink a glass of milk, or sometimes they just decide to start cleaning. Actually, these activities that I just mentioned perpetuate the problem.
I'm going to ask a follow-up question, if you don't mind. Can you talk about the use of medications to try and keep you asleep versus other methods to treat difficulty going back to sleep in the middle of the night?
Sure. So primarily, how do we treat insomnia? We primarily treat with behavioral interventions, and this is our guideline recommendations from the American Society of Sleep Medicine. And in some occasion, it's allowed, and we use some sleeping medications to make the patients feel sleepy. However, in some circumstances, these sleeping medications may cause some psychological effect on dependency, thinking that you fall asleep because of the medication, not because it's nighttime, you're in your room. So this is why if we use medications that in some occasions is necessary, we prefer to use it with both behavioral interventions with medications.
All right, thank you very much. Dr. Brubaker, what is considered good sleep? How many hours do you need? How much time should we be spending in each stage of sleep? Can we get too much sleep? And does it change as you mature from a teenager to an adult?
So I would define good sleep as high quality sleep that occurs for the appropriate duration for your age, and most importantly, that you find restful. So we know that as people age, they require less sleep. So newborn infants require, somewhere between an average of 14 to 17 hours. Teenagers are in that 8 to 10 hour window. And then as we approach our 60s, 7 to 8 hours is considered a typical sleep duration. So I think we want our goal to be to get the adequate amount of sleep for our bodies. As far as each sleep stage, I'm not sure that I would focus too much on sleep staging, so to speak. I think that's something that's best left to the experts, and probably, the only time that would be important is during a sleep study that's going to be interpreted by somebody with very good knowledge of sleep. But can you get too much sleep? So this is a tricky question. I think, yes, you can get too much sleep. We know that there are some negative effects linked to too much sleep, particularly in adolescence. Things like suicidal thoughts and hypertension, as well as disruptions in metabolism. But I think the way I would look at it is that oftentimes getting too much sleep is an indication that there's some other disorder or problem or medical or psychological concern going on. So if I hear of a teenager that's sleeping, 14, 15 hours per day, or an adult who gets 10 hours of sleep and still doesn't feel rested, I'm not really concerned about how much longer they're sleeping, but rather why they feel that they need that much sleep. And so I think in that particular situation, we want to do a deep dive into their sleep hygiene and how they're sleeping and if they're snoring and things like that.
Dr. Decoy, how does lack of sleep affect your brain, heart, and mental health?
Lack of sleep is common in our society today. And as the doctor just mentioned, that for most adults, a normal amount of quality sleep time is 7 to 8 hours per night. And if a person is not getting that, then it certainly decreases their reactivity, sometimes their attention span. They will be excessively sleepy during the day often. They may wake up feeling tired and will psychologically not be, so to speak, at the top of their game. It also has cardiovascular effects in that it does make an individual prone to irregular heart rhythms. Usually a lot of times fast, irregular heart rhythms can occur. It can also make people prone to uncontrolled high blood pressure issues. And those issues can lead obviously to heart problems and even to strokes. So a lack of sleep is a very important problem we have in our society and should be looked at, because how each individual, particularly men and women, differ in their perception of quality sleep is important.
Dr. Pina Urbaya, is it true that as we age, it's harder to fall asleep? Do we not need as much sleep as we get older as when we were young? Dr. Brubaker covered a little bit of this earlier, but what's the difference in the ability to fall asleep or sleep problems as we get older?
Yeah, so to answer your first question, is true, is physiologically normal that as we age, it's harder to fall asleep. Then the second question is, do we need as much sleep as younger people? The answer is yes. So when we age, there are normal physiological changes that occur. In the elderly or older people, the brain tends to shift back. So meaning that the elderly have a tendency to sleep earlier and perhaps wake up earlier as well. Sometimes when, as I mentioned previously, it's normal that can take longer to fall asleep, which is why it's important for people to get a wind down time before going to bed and doing those promoting activities that I just mentioned before, and also avoiding screen exposure, because screen exposure, meaning iPads, iPhones, TVs, because doing these activities engage the brain and promote wakefulness. So it's going to be harder to fall asleep. Naps sometimes in the elderly population is common, and that can also aggravate or will make people difficult to fall asleep at night. Naps are still allowed, but they should only last 10, 15 minutes at the most. Another important aspect that I would like you to remember is that when we age, the amount of the sleep time that we spend in deep stages of our sleep is less compared to young adults. However, despite these physiological changes that I just mentioned, we still recommend to sleep 7 to 8 hours, because poor sleep in the elderly has been recommended with increase of delirium, falls, depression, and heart problems, as Dr. Decoy mentioned.
Yes, as Dr. Decoy mentioned before, that mental health and sleep are related. But let me ask you a question. You mentioned that as we get older, sometimes our body clocks shift and we go to bed earlier. And when I say we, I don't know that I include me in the older population yet. But is that truly a problem? Or is this just a natural phenomenon? Is it something that needs to be fixed?
No, not necessarily. So it becomes a problem if this new time doesn't align with your lifestyle. So this is when it will become a problem, because let's say, so generally when we talk about a 70-year-old, 80-year-old, they are going through retirement. So sometimes they can wake up at any time, or the same thing, they can sleep at any time. So it actually becomes a problem when there is not alignment with the style life. Otherwise, I wouldn't. This is not a problem, and we generally don't address it unless the patient come to us and tell us, I'm falling asleep earlier, and I would like to be able to spend more time with my grandkids or my wife, or perhaps sometimes patients can be, 80 years old and they are still working. I have so many patients at this age, they are still working, they are lawyers, and they just want to be awake. So this is where we work as a team and do those interventions.
So it's basically only a problem if there's a mismatch with your social situation and the timing of sleep.
Exactly.
And that seems to be the same for people who are night owls as well, who go to bed at 1, 2, or 3 o'clock in the morning, right?
Exactly. And they need to wake up at 6 or 5 or 7 a.m. And they're, as a result, what is going to happen? They're going to start having daytime symptoms. But there are some people can be night owls and, they work second shift. So there isn't a problem there.
So bartenders and food service and entertainers all do well if they're night owls.
Yes.
Dr. Decoy, our second most common question was about sleep apnea. Obviously, this is a very big topic. So the big questions were, what is it? How does one know if they have it? And what are the treatment options? And because we know you're going to say CPAP is the treatment options, like what are the alternatives to CPAP?
Well, obstructive sleep apnea, first of all, as we say, is a condition in which a person is either not breathing or breathing very shallow when they sleep at night. And it usually lasts for roughly 10 seconds. And there will be a drop in oxygen levels, which may also correspond to an increase in carbon dioxide levels in the bloodstream. And so this can create irregular sleeping patterns through the night. And folks will often report, as has been talked about here, that they may wake up at night frequently, unable to go back to sleep, or they may wake up to have to go to urinate for unexplained reasons to them. And all that creates a broken sleep pattern at night. And then folks will often wake up in the morning, whether it be at an earlier or later time, and will often feel unrested. They may wake up feeling confused or in a daze, or they may just still be sleepy and not want to get up. And some patients will describe a headache or a pressure feeling in their head. And so then that's all because of not getting consecutive, what we would consider to be a normal amount of time sleep, which is roughly 7 to 8 hours of consecutive sleep. So then during the day, the person will complain perhaps of being sleepy, unable to stay awake at their job, unable to stay awake if driving long distances. They may fall asleep at a stop sign or a stoplight. If they sit down to read a book or a newspaper or watch TV, they can't stay awake for that. So those are all the things that we look at with obstructive sleep apnea. And obstructive sleep apnea is a condition that in general is more common in men than women, usually twice as much more men than women. And for a man, the most common complaint will often be I'm sleepy all the time, or I can't stay awake, or I snore a lot. Snoring is also a sign that occurs both in men and women, but the snoring by a man for his bed partner will often be something to bring him to the doctor. For a woman, however, the most common complaint of a woman with obstructive sleep apnea is insomnia. I can't go to sleep. I can't get to sleep, or I can't stay asleep. And so they're two different things. So we look at it, from that standpoint of the patient. And then if we feel that the conditions are set for that, and usually there's as people get into middle age, weight gain is directly related to severity of sleep apnea. Then we'll do a sleep study, which is an overnight sleep study, a study in a sleep lab, to where you would be connected to a lot of different wires and electrodes, and we measure a lot of things about your body at night and tell whether you have sleep apnea. Or if we feel that the symptoms are such that there's a very high probability that's what the patient has, then we are starting to do now more what's called home sleep apnea testing, which is a test in which the patient will pick up a kit with some things in it that they will wear at night when they sleep, and then return it to the sleep center the next day. That will be read by a sleep doctor to tell if you do have sleep apnea. So then if all those conditions are met and it qualifies for obstructive sleep apnea, then as Dr. Kaminsky has already alluded to, then we'll look to start people on CPAP, which stands for continuous positive airway pressure. And the way I like to contrast that is like an air splint. And everyone sort of knows, like, if you have a splint, you keep a window open or a door open. CPAP is like an air splint that you wear either over your nose or over your nose and mouth, or under your nose, in various different shapes and contortions that we now have from technology, that acts to keep your throat open in the night when it would tend to collapse, when you would tend to have a sleep apnea event. And CPAP is usually started by having the patient go back to a sleep lab, which we have many sleep labs here in Northeast Ohio from the Cleveland Clinic. And you would go in and be fitted with a mask and would be titrated to the appropriate pressure that would eliminate your sleep apnea. And we also, though, are now also using what's called an auto CPAP or an auto PAP device, in which the doctor will program in a minimum pressure range up to a maximum pressure, usually somewhere between 5 and 20 centimeters of water pressure. And then the patient will wear that at night, just like they would if they went into a regular sleep lab for a titration study. And then usually the doctor will order what's called a download assessment, to where the home medical equipment company will use the computer that's in the CPAP machine to see how often the patient is wearing it, how many nights per week, and then how many hours per night. And then that's translated into what we call an AHI that your doctor will talk to you about, called the apnea-hypopnea index, meaning the number of times in which you stop breathing and also that you breathe very shallow. And what we look for is a number that's less than 5 to be normal. So if you're above 5, then you probably may still have a problem, but that's how we assess that. And to be successful with this, we tell patients they need to wear this, first of all, as often as they can, as much as they can at night, but at least 6 hours per night, at least 4 to 5 hours or more per night. And studies have come out in recent time that shows that the more you wear it, the better you do. So if you wear it 6 or 7, 8 hours a night, you're going to do better if you wear it 4 or 5 hours a night. So it's highly successful. And I like to tell patients that it's non-invasive. It doesn't require Dr. Kaminsky doing anything. It doesn't require any medicines, doesn't require any blood work. It's totally non-invasive, and it works over 97% of the time if a person is compliant with it, as I just described. So we obviously like to try and get patients to try this first before we would move on to other therapies.
Don, can I go back to the beginning of your answer when you're answering the portion of the question that said, how do I know if I have sleep apnea? Can you talk about some of the traits or physical findings of patients which may increase their risk of having sleep apnea, say, for example, their weight or body mass index and some other things that would lead you to want to do further testing?
Yeah. First of all, if a patient comes and a lot of times, as I said earlier, what will bring them to the doctor is the fact that a lot of times it'll be from their bed partner that they snore and they can't sleep with them. So they may be snoring a lot. They may have episodes in which they are observed to stop breathing in their sleep. They may wake up making a grunting or a gurgling sound from sleep. They're often described as being restless sleepers, both either by themselves or by their bed partner. Patients' bed partners have told me that they are tossing and turning, kicking them in the back, throwing the covers off the bed, things of that sort. And that all creates disruption of sleep. And then, as I mentioned, also unexplained episodes of getting up to urinate at night is also a sign to look for. So as far as a patient's appearance, it's often body weight is a major factor. And certainly we think that people may be prone to developing sleep apnea just on the way you're made, based on the shape of your neck, your throat, your mouth, your tongue. Those are all things that can go into it. But if you have those things, and as we gain weight a lot of times, as we get into middle age, then that accelerates the problem. And so we define what's called a body mass index as being greater than 25 as being overweight. So as the body mass index increases, the propensity or the significance of sleep apnea will become more apparent and more obvious, and would certainly propel the doctor to want to do a sleep test.
So as you said earlier, Dr. Decoy, the CPAP machines are very smart, and they have sensors within them that can let us know how successful the treatment is. Dr. Brubaker, what do you think of sleep trackers? Not CPAP machines, but the wearables that patients can buy. What are they? Are they accurate? Can we hang on every output from those sleep trackers to determine what's going on?
So this is a really hot topic right now. There are a variety of sleep trackers that are available on the market, and they come in all different types. There's rings, there's watches, there are apps that you leave your phone on next to your bed. And I think from a personal use perspective, they're probably all mostly pretty accurate at detecting sleep duration. And I think as a consumer, that's probably why most patients of mine purchase these devices. And I think I do look at them clinically when I see patients in the office to help me get an idea of what they're sleeping and what their sleep pattern looks like over significant amounts of time. And for that reason, I think that they're really, really nice. As far as what they're not so good at is sleep staging. And again, we're back to the sleep stages. I have a lot of patients ask me, my Apple Watch tells me that I don't get enough deep sleep. And they're concerned about this because they're in the mindset of wanting to meet the goals of, meet the fitness tracker. Did you walk enough steps? Did you do your 30 minutes of exercise? And so they're in this mindset of having to meet this particular goal. And I really try to not focus on the sleep staging, because the formulas that the different sleep trackers use are usually proprietary. So we don't know what decision making the different trackers use to determine if sleep is deep or not. And you can estimate probably its level of movement. So tossing and turning might be perceived as less deep of sleep than somebody who's not moving at all. But because we don't know that, I really don't put a lot of effort or faith into, taking that into consideration. So I think they do a good job in duration, but maybe not so much in staging. The only other particular area of concern that I have is for infant trackers. There's a lot of trackers on the market for infant sleep, in an effort to give parents safety give parents reassurance that their infant is safe. there's not a lot of data that proves that outcomes for infants that are using these monitors are better than infants that are not using monitors. So I don't really put a lot of faith into those, but I think the technology is developing. Every day I hear something new. Patients will come to me with recordings of their snoring, and they will actually have recorded an apnea, which I think is clinically helpful and relevant. So I think they have their place, and I think the data is getting better and better. Right now, if the patient came to me with sleep concerns about the quality of their sleep, I would utilize whatever data they bring to me and then probably recommend a medical sleep monitor, which is a monitor which does essentially the same thing, but we know the algorithms that it uses to score different activity and sleep stages and stuff like that. So yes, I think there's a place for them. I think we are learning every day how to use them better. There's a lot of research in this area. There was an entire one-day conference that I attended in April where they reviewed the various different sleep trackers that are on the market and the different things that they recorded. So I think it's just going to get better and better as time goes on.
It's great. We live in a wonderful time, considering that sleep medicine is a very young field. The overlay of timing of sleep medicine as a developing field is nicely integrated with the advancement of all this technology, which is great. The next question, I think I get to answer. That makes it my favorite question of the night, I think. So the question is there corrective surgery available for obstructive sleep apnea? I've used CPAP for years now, been having problems keeping the mask on my face through the night, and I'm having lack of sleep because of it. So this is a loaded question. And the reason that it's loaded is surgery to correct sleep apnea is not an alternative. It's not an either or. It follows a sequence that you try CPAP or a non-invasive therapy, and if it is not possible to tolerate it through whatever mechanisms to try and improve your tolerance or adherence, revisiting the respiratory tech, different masks, various maneuvers to try and get you used to it, then is the time to consider an alternative such as surgery. So surgery for obstructive sleep apnea traditionally has been something called uvulopalato-pharyngoplasty. This big long-term, or for short UPPP, started back in the early 1980s and has been the mainstay for many, many years. It includes removing tonsils if there are still tonsils present. Originally, it was a trimming of the edge of the soft palate to shorten it so that it couldn't collapse, and then sewing all of that up. Over the past 40 years, there have been variations of this surgery to try and make it less painful afterwards and increase the effectiveness. The effectiveness of this type of surgery, probably around 50%. Imagine having your tonsils out as an adult, and the time for recovery would be a good 2 weeks, and it's very uncomfortable. So people throughout the years have been trying to find other ways to treat sleep apnea. Also around just about as long is what I would call the granddaddy surgery of them all, which is bony surgery, usually done by a plastic surgeon or more commonly an oral surgeon. And that is something called MMA, or maxillomandibular advancement. And that is dividing the bones of the jaw here and the upper jaw here and sliding the whole complex out a few millimeters and then reattaching it. That success rate is probably around 85 to 90%. It is a big surgery and it is very successful, it's just that a lot of people just won't accept that type of surgery, even though it is very, very successful. So about 8 years ago, came on the market a new type of therapy called hypoglossal nerve stimulation. If you watched TV in the past year or two, you've probably seen advertisements for this. There's only one on the market. It's called Inspire. I am not paid by Inspire. This mention of their name is only because it's the only one on the market. And Inspire, what that does, it's an implant that's like a pacemaker for the tongue. So once we figure out if people are candidates for this surgery, and there are certain criteria, it's probably too detailed to get into on this answer right now. But once it's implanted and you turn it on at night, it moves the tongue forward. By moving the tongue forward, it pulls the soft palate forward and it opens up the airway. It's turned on with a remote at night and turned off by a remote in the morning. And this is probably around 75% chance of success. So it's very, very promising. And we have lots of data over this time period to show that it is quite durable. So to summarize, yes, there are ways to correct sleep apnea for those who are unable to tolerate CPAP or a non-surgical method of treating sleep apnea. So to totally turn around to a non-sleep apnea question, Dr. Pina Urbaya, the question is, how do I fix my circadian rhythm? That's kind of a broad question, but hopefully you can tailor it to something that our audience would understand and like to hear.
Yes, so this is another common question that I generally receive from my patients when they come up front and they come and tell me, I think I have a circadian rhythm problem. So I think to begin answering this question, I think it's important to kind of define, what is circadian rhythm. And circadian rhythm, what basically is our 24-hour internal clock. And this internal clock that we have not only regulates our body sleep-wake cycle, but also regulates hormonal secretion, metabolism, the immune system. And it's important to remember that everyone's internal clock is different. This is where some people are night owls, and we mentioned about this before. Other ones are early risers, for example, and there are other people that are somewhere in between. And this is totally normal. And as long as I mentioned before, this aligns with your lifestyle and social life as well. However, in some occasions, there are extremes, and people have the tendency to fall asleep early morning, 4 or 5 a.m., and they wake up 2 or 3 p.m. in the morning. And this is what we call delayed sleep-wake phase disorder. We have also the opposite, those people that fall asleep early in the afternoon, 5, 4 p.m., and they are already awake by midnight or 1 a.m. And these are the group of people that we call that they have advanced sleep-wake phase disorder. And what symptoms do these two group of people generally have? They have daytime sleepiness, they have fatigue, they have memory problems, just because when they need to be awake, they can't. And this is where I would recommend that if you're experiencing any of these symptoms, you should seek a sleep medicine specialist, because the management generally is with melatonin and light therapy, but it's very important to know the specific timing, and it's very difficult for me just to mention at this moment, just you take melatonin at this specific time, because each case is different. But overall, how we treat circadian rhythm problems, and the most common ones are those two that I just mentioned, is with light therapy and melatonin. And one thing that I think I should add as well is that it's very common to confuse circadian rhythm problems with insomnia. Sometimes patients feel that they just have an insomnia problem, I cannot fall asleep, and they have been treated for years with a sleeping pill and nothing is working. And the problem is because it's a circadian rhythm disorder. And this is why sleep medicine specialists will help differentiate these two disorders. It's true sometimes that both can occur at the same time, because this problem generally starts several years back, and patients, to cope with this issue, they start having some interventional or some behavioral changes which actually cause insomnia, which is why in many occasions, in addition to light therapy and melatonin, we recommend behavioral changes as well.
Can you tell us, do you think people can do melatonin and light therapy on their own, or do they need to be under the guidance of a professional?
It should be guided by a professional, because these can also have side effects. And in many occasions, these type of patients can have other concomitant medical conditions, such as I'm just giving an example, migraines, or they already feel sleepy and drowsy and fatigue, or as I mentioned, they also can have concomitant sleep disorders such as sleep apnea and insomnia. So when there is a circadian rhythm problem, the case becomes a little bit more complex, that require some special guidance from a provider.
And if you do light therapy the wrong way, you can shift it in the wrong direction.
That is a good point. Yes, actually, if you don't do these measures or these interventions at the right time, you can actually do the opposite and aggravate the situation. That's totally accurate.
Dr. Decoy, Dr. Pina Urbaya talked about melatonin in regards to circadian rhythm disorders. Can you talk about just the general idea of melatonin? Is it safe to take? When should you take it? How much should you take? In regards, I assume that this question is about insomnia, having difficulty falling asleep.
Yes, and that's we often get asked that about taking melatonin, and a lot of patients will want to take melatonin to help with sleep onset, saying that they can't get to sleep for, maybe, as we say, the normal sleep time, sleep onset time is, between 10 to 20 minutes, and they may not be able to get to sleep for an hour or longer. So what about melatonin? Melatonin is a naturally occurring hormone that's made by a small gland in the brain called the pineal gland. And it's usually made, as Dr. Pina Urbaya has already alluded to, it's made at certain times, usually in the time in the evening around what's called the minimum body temperature or core body temperature. And so we will often tell folks that they can try that. Usually the dose is anywhere between 0.5 milligram to 5 milligrams. It doesn't take very much. And to take it usually 2 to 3 hours, or sometimes even 1 to 5 hours before their desired sleep time or bedtime. Patients usually tolerate it well. Sometimes the patient may have side effects of upset stomach, nausea, headache. Rarely a patient may have a hangover the next day from that, but that's very unusual to occur, but it is reported. And it's usually something that we would, before giving a quote unquote sleeping pill to help someone to entrain to sleep, we would probably recommend that because it's easily obtained. You don't have to have a prescription for it, and it comes in multiple doses. And like I said, we usually will recommend between anywhere from 0.5 to 5. And I usually will not tell people to go higher than 3 milligrams when they start out using it. But usually it's a easily obtained and for the most part very well tolerated medicine. That's a naturally occurring chemical that the body makes.
So if you're using it for falling asleep, for insomnia, when should you take it? Should you take it after you brush your teeth and you jump into bed, you take your melatonin, or?
Usually I will tell people to take it. I will tell people to take it anywhere from 1 to 3 hours before their scheduled bedtime. And if their bedtime is somewhere between 9 and 11 o'clock, then I would tell them to take it probably roughly around 7 o'clock to start taking it.
Great, thank you. So obviously we know that weight affects obstructive sleep apnea and makes it more common. Dr. Brubaker, overall, how does weight affect sleep? And how does lack of sleep affect weight?
This is an excellent question. And as we are all aware, our rates of increased weight gain, obesity, and overweight in both pediatric patients or adults and children, everyone is gaining weight faster and more. And so many studies have looked into what factors are contributing to excess weight gain for our kids and adults. And insufficient sleep has actually been very strongly linked in the literature with excess weight gain for adults and for children. And so I think this is an important area of focus for all of healthcare to really sort of get into the nitty-gritty with patients about their sleep, because it is a modifiable risk factor for weight gain. And so if you or your family members or your children are having poor sleep, there's a lot to gain from investigating and trying to fix it. There is the chicken and egg argument, as well as insufficient sleep leads to weight gain leads to sleep apnea and other reasons for poor sleep. So I think it's a really, really important relationship to investigate it in all patients. But the data is definitely there.
So if you are overweight and you have obstructive sleep apnea, there are hormonal changes at night that are affecting your weight, are there not?
There are. So insufficient sleep has been shown to increase both ghrelin and leptin levels in patients, or affect them, I should say. And both of those influence appetite. And so there's a lot of research looking into exactly in what direction those relationships work. But they are definitely there. So for patients with insufficient sleep have been shown to have decreased satiety. So it takes them, they don't feel as full as quickly as they should. And similarly, they have a higher appetite. So yes, that is true.
All right. So the next question is, how dangerous is snoring? And I'll ask myself. And so the question of how dangerous is snoring, I think, is multi-layered. So when we talk about snoring, we have to make sure snoring is not associated with obstructive sleep apnea. So we have a way of describing snoring that is snoring alone, and that's called primary snoring. And primary snoring means that it is just making noise, not related to obstruction of your airway. And so the question, how dangerous is that? Well, I guess it has not been proven that primary snoring does have serious health effects. It has a lot of social effects, because people won't stay in the same room as you when you travel. Your family can hear you across the house. So there's a lot of things that will make it so It's socially dangerous. You know, I read once about 25% of couples do not sleep in the same bedroom, and snoring is the main reason why. So the dangerous part of snoring is when it's part and parcel of obstructive sleep apnea. And I won't go into obstructive sleep apnea again because Dr. Decoy did a wonderful job earlier in the presentation to talk about obstructive sleep apnea, but that's truly the dangerous part because it does increase your risk of abnormal heart rhythms, coronary artery disease, strokes, cognitive changes. There's all sorts of things. So it's not snoring alone that's dangerous. It's the snoring with another sleep problem, such as obstructive sleep apnea. Earlier, we did talk about drugs, prescription drugs for falling asleep. Dr. Pina Urbaya, could you discuss the difference between prescription drugs, over-the-counter drugs, natural supplements to help with sleep? And what are the pros and cons of each?
Well, if someone has difficulties falling asleep or staying asleep, it's better to consult to your health provider because treatment will depend on what is causing your insomnia and also when the insomnia is a problem, either when you are trying to fall asleep or either when you are trying to stay asleep, or in some occasions it's both. And again, I think I mentioned this earlier, that I would like to emphasize that cognitive behavioral therapy is generally the recommended therapy for insomnia. There are times that a sleep aid is necessary to get you feel drowsy and help you get to sleep. However, it's important to remember that all type of medications, even natural medications, can have side effects. And more importantly is that some of them can interact with some of the medications that you might be taking, which is why even if you're taking a supplement medication, it's important that this is supervised by your medical doctor. So when we talk about the difference between all these different types of prescribed medications, under-the-counter medications, and the natural medications, so basically the difference is that prescribed medications are FDA regulated, so they go through a very rigorous process to go outside the market, and some of these medications, the effect varies depending on when the problem is occurring. As I mentioned before, they work for those patients that have problems falling asleep. There are other medications that will work for both a sleep initiation problem and staying asleep as well. And there are other ones that is just for sleep maintenance as well. So when we talk about over-the-counter medications, these medications, they don't go to that FDA rigorous process. And these are generally antihistamines, those medications that people would take for runny nose, cough, a common cold. And these generally, we don't use it as a sleeping aid. And these natural supplements, the difference with these other two is that these are not FDA regulated at all. So actually, when we talk about melatonin, this is an example that because these are not FDA regulated, the amount of melatonin in all these pills that you can see in different stores, you actually don't know. So it may be 5 milligrams, but the actual amount of melatonin that is in those 5 milligrams is not known because these medications are not regulated. But all these medications, all these natural supplements, that is not only melatonin. Sometimes people can use valerian, kava. This can also have side effects, which is, again, important that this is discussed with your doctor. And to summarize these, all sleeping aids can be used as, and primarily is recommended to combine it with cognitive behavioral therapy. And if they are used, it's recommended just for a short term only.
Great, thank you. Well, the time has flown so far. I and we have time for one more question. Dr. Decoy, you get the final question of the evening. And this is about shift workers. So the question is, I work 4 nights in a row, 9 p.m. to 5 a.m., and then I have 3 days off. What should my sleep schedule be for a healthy life?
Well, this is a very difficult problem and something that we see a lot of in patients, particularly in today's society. For a patient who works what's called the night shift, the patient is usually recommended to try and sleep a maximum number of hours as they can, usually 6 to 8 hours before going to work, waking up, and usually a couple hours before they actually go to work. And then during the night, if they do have trouble staying awake at night, we often recommend that they try to get a short nap. And that may be a nap that, over their, what would be their lunch break at night. And then when they get off of work at 5 a.m., as you say, sometimes we even recommend that a patient will take a short nap before driving home, so as not to endanger themselves from falling asleep. We usually will recommend that they expose themselves to bright light when that's the case, and then to go home and then prepare for what would be an appropriate sleep period while they're home before going back to work. Now, in saying that, patients may still have problems with sleepiness or fatigue during their shift, and there are some medications that we sometimes will use called stimulant medications, one of which has been approved and is used frequently in people with shift work sleep disorder. It's called modafinil, and it's usually given before the patient will go to work by usually 1 to 2 hours before going to work. And they may even take it during the middle of their shift if they continue to still have problems. So they can take it potentially twice a day, but we'll usually start with a dose before going to work by a couple of hours. And this works rather well. And patients can maintain normal, appropriate functioning at their job. And if dosed in the right manner with the right amount, then they're usually able to achieve an appropriate sleep period when they're home. However, as everyone on the panel has already discussed, it's very appropriate that they approach their sleep pattern just as they would as if they were sleeping at night if they worked a normal shift during the day, and that the sleep room and the sleep environment be conducive to sleep, and that it be dark, and that it be not hindered by television, radio, computers, cell phones, to get, like I said, usually at least 6 to 8 hours, roughly 6 to 8 hours of sleep during that time.
Great. Thank you so much. I want to thank all of our experts on the panel this evening. We've gotten to the end of our Cleveland Clinic Ask the Expert event. So thanks everybody for attending. We will send you a post-event email in the next day or so with important information about what you just heard, links to all kinds of sleep health resources, and details how to make an appointment. It will also include a link to a recording of this event so you can view it again. Thank you and good night.